Welcome to Mental Health Strategies for Rehabilitation Teams, an interprofessional approach. Mental health conditions, especially depression and anxiety, represent a widespread and serious challenge in rehabilitation medicine. Across geriatric, neurological, cardiac, and orthopedic populations, comorbid mood and anxiety disorders, meaning mood and anxiety disorders that co-occur alongside the primary medical condition, emerge as powerful drivers of functional recovery, treatment adherence, and long-term quality of life. For rehabilitation professionals, including physical therapists, occupational therapists, nurses, and allied health clinicians, the ability to recognize, understand, and address these psychological barriers isn't optional anymore. It's fundamental to achieving meaningful patient outcomes. Contemporary evidence has changed our understanding of how depression and anxiety intersect with physical rehabilitation. What was once considered a secondary concern, a patient's emotional state during recovery, is now recognized as an independent predictor of functional outcomes across virtually every rehabilitation population studied. Patients who present with depressive symptoms demonstrate lower functional independence at discharge, reduced likelihood of regaining mobility, and diminished quality of life. Those with anxiety exhibit avoidance behaviors and reduced engagement in the therapeutic activities that are essential to recovery. Depression-related amotivation, the loss of initiative and drive to engage in purposeful activity, and anxiety-driven avoidance are among the most significant barriers to treatment engagement during physical rehabilitation. Addressing these barriers requires a multimodal, evidence-based approach integrating psychotherapeutic, behavioral, and physical activity interventions. The clinical implications are clear. Rehabilitation professionals who lack the knowledge and skills to address these comorbidities risk delivering care that's technically proficient yet therapeutically incomplete. This course equips interprofessional rehabilitation teams with evidence-based strategies for integrating mental health awareness and intervention into routine clinical practice. Participants will examine the epidemiological and clinical evidence linking depression and anxiety to impaired functional recovery, providing a foundation for understanding why mental health screening and intervention should be embedded in rehabilitation care as an evidence-based standard of practice. The course introduces motivational interviewing as a patient-centered approach to enhancing engagement and overcoming the ambivalence and resistance that frequently accompany comorbid mood disorders. The therapeutic alliance, the working relationship between clinician and patient, is explored as a critical mechanism through which rehabilitation outcomes are improved, particularly for patients whose psychological distress threatens their capacity to participate fully in treatment. Beyond these foundational strategies, the course addresses behavioral approaches to amotivation and avoidance, including behavioral activation, physical activity integration, and adjunctive psychotherapeutic modalities. We'll examine adaptations for adolescent, adult, and geriatric populations, along with setting-specific modifications for inpatient, outpatient, and home care rehabilitation environments. The course also covers validated outcome measures for depression and anxiety, integration of mental health metrics into electronic health record workflows, and the principles of measurement-based care, which is the systematic use of validated outcome measures to guide clinical decisions. Interdisciplinary team communication, structured discharge planning, and digital health tools for maintaining mental health continuity across care transitions complete the didactic content. 4 clinical case studies provide opportunities to apply course concepts in realistic rehabilitation scenarios spanning diverse patient populations and care settings. By the end of this course, participants will possess a thorough, evidence-based framework for recognizing and addressing depression and anxiety within their scope of practice, enhancing both the quality of rehabilitation care and the functional outcomes their patients achieve. Upon completion of this course, the learner will be able to identify the effects of depression and anxiety on functional recovery and rehabilitation, describe the core techniques of motivational interviewing used in rehabilitation, explain how the therapeutic alliance influences functional outcomes in rehabilitation patients, recognize evidence-based behavioral strategies for addressing amotivation during rehabilitation, list key adaptations of motivational interviewing for different rehabilitation populations, define validated outcome measures for depression and anxiety used in rehabilitation, and state the components of effective interdisciplinary team communication for mental health continuity. Module 1 examines the impact of depression and anxiety on functional recovery, beginning with the prevalence of these conditions in rehabilitation populations. Depression and anxiety are among the most prevalent psychiatric comorbidities encountered in rehabilitation settings, affecting patients across the full spectrum of diagnostic categories, age groups, and care environments. Understanding the scope and magnitude of this challenge is essential for rehabilitation professionals who seek to optimize functional outcomes and deliver thorough, patient-centered care. The epidemiological evidence consistently demonstrates that depressive and anxiety symptoms aren't occasional or incidental findings in rehabilitation populations. They represent a pervasive clinical reality that demands systematic attention and proactive intervention from the entire interprofessional team. In geriatric inpatient rehabilitation, depression assessed by the Geriatric Depression Scale 15, or GDS-15, has been established as an independent predictor of lower functional independence measure, or FIM, scores at discharge. And this finding is statistically significant, meaning the relationship is almost certainly not due to chance, after controlling for baseline disability, pain, cognition, and educational level. This finding is clinically significant because the FIM is the most widely used measure of functional status in inpatient rehabilitation. The independent contribution of depression to FIM outcomes beyond the influence of physical impairment, pain, and cognitive function shows the degree to which mood disturbance can undermine the rehabilitation process even when physical and cognitive factors are adequately addressed. Rehabilitation professionals must recognize that depression isn't merely a correlate of functional decline, but an independent predictor associated with diminished capacity to benefit from therapeutic interventions, regardless of the severity of the underlying physical condition. The prevalence of depressive symptoms among older adults undergoing inpatient rehabilitation is substantial. Research demonstrates that approximately 31 to 32% of geriatric rehabilitation inpatients present with clinically significant depressive symptoms. Critically, this prevalence remains consistent regardless of whether the primary admitting diagnosis is stroke or a non-stroke condition. That suggests the experience of rehabilitation itself, characterized by functional limitations, dependence on others, and uncertainty about the trajectory of recovery, may contribute to depressive symptoms independent of the specific medical condition being treated. Depression negatively affects functional ability at discharge across both stroke and non-stroke populations, reinforcing the conclusion that mood disturbance is a universal, rather than disease-specific barrier to functional recovery in geriatric rehabilitation. This consistency across diagnostic groups argues for routine, universal screening rather than screening protocols that target only patients with conditions traditionally associated with psychological distress. Among Medicare beneficiaries, the burden of depressive and anxiety symptoms following nursing home or inpatient rehabilitation is even more pronounced. The prevalence of depressive symptoms in this population reaches 38.8%, and individuals who receive rehabilitation services face more than a threefold increase in the likelihood of subsequent depressive symptoms compared to those who did not receive rehabilitation. A finding that is statistically robust and remains significant even after adjusting for other contributing factors. The magnitude of this association, indicating a more than threefold increase in risk, suggests that the rehabilitation experience is associated with an elevated risk for the development or worsening of mood disturbance. This association may partly reflect confounding by indication, a bias that occurs when the reason for receiving treatment is also related to the outcome in vulnerable older adults. It perhaps reflects the psychological impact of functional loss, institutional placement, and the physical and emotional demands of intensive therapeutic programming. Taken together, these epidemiological data provide a strong evidence-based rationale for rehabilitation professionals to integrate systematic depression and anxiety screening into routine clinical protocols. This is consistent with emerging best practice recommendations, given that approximately 1 in 3 to 4 patients will present with clinically relevant depressive symptoms during their course of rehabilitation care. Beyond their high prevalence, depression and anxiety function as independent predictors of poorer functional recovery. This relationship has been demonstrated with remarkable consistency across diverse rehabilitation populations, settings, and outcome measures. The clinical significance is substantial and well documented, as it establishes depression and anxiety not as secondary considerations in rehabilitation care, but as primary determinants of the outcomes that rehabilitation teams are charged with optimizing. Pre-existing depression in community living older persons is associated with a significantly lower likelihood of recovering mobility function after a disabling hospitalization, with a statistically significant reduction in recovery rates that is almost certainly not attributable to chance. What this means in practice is that for each unit increase in depressive symptom severity prior to a disabling event, the probability of regaining mobility is reduced by approximately 21%, even after accounting for the severity of the disabling condition and baseline functional status. The implications for rehabilitation planning are immediate and actionable. Patients entering rehabilitation with a documented history of depression or elevated depressive symptoms at admission require proactive monitoring and targeted intervention to counteract the established negative effects of mood disturbance on recovery trajectories. The predictive power of baseline emotional health extends across multiple categories of acute medical events. High baseline depressive symptoms predict substantially lower odds of functional recovery 1 year after stroke, heart attack, or hip fracture, a finding that is statistically significant and unlikely to be explained by chance alone. That means patients with significant premorbid emotional health challenges are less than half as likely to achieve functional recovery compared to their non-depressed counterparts. This finding is particularly noteworthy because it demonstrates that the impact of depression on rehabilitation outcomes isn't confined to a single diagnostic category. Instead, it operates as a transdiagnostic risk factor, a risk factor that cuts across multiple diagnostic categories, compromising recovery regardless of the precipitating medical event. The consistency of this evidence across stroke, cardiac, and orthopedic populations argues strongly for universal, rather than condition-specific approaches to mental health screening and intervention in rehabilitation settings. National clinical practice guidelines from multiple specialty organizations have codified these findings into formal practice recommendations. The American Heart Association and American Stroke Association guidelines explicitly state that post-stroke depression exerts negative effects on functional recovery and recommend that pharmacological treatment be considered to counterbalance these effects, noting that remission of depression is associated with greater recovery in activities of daily living. Similarly, the American Academy of Orthopedic Surgeons, or AAOS, evidence-based clinical practice guideline reports that increased depression at multiple time points following orthopedic injury is associated with decreased functional outcomes, lower quality of life, and reduced patient satisfaction. The AAOS systematic review identified no studies in which depression was associated with positive outcomes at any stage of orthopedic trauma recovery. That finding highlights the uniformly harmful impact of untreated mood disturbance on musculoskeletal rehabilitation. The convergence of these guideline recommendations from major national organizations provides a compelling and authoritative rationale for integrating mental health assessment and intervention into standard rehabilitation protocols across all clinical settings and patient populations. The consequences of depression and anxiety in rehabilitation extend well beyond standardized measures of physical function to encompass broader domains of patient well-being. Clinicians, researchers, and accrediting bodies increasingly recognize these domains as essential indicators of treatment effectiveness. They include workability, health-related quality of life, and patient satisfaction, and all of them are directly affected by the presence and severity of comorbid mood and anxiety disorders. In psychocardiological rehabilitation, an approach that integrates psychological and cardiac care, higher baseline depressive symptoms have been shown to significantly increase the odds of limited workability, with roughly 78% higher odds of limited work capacity, a finding that is statistically significant and highly unlikely to be due to chance. This carries significant implications for working-age patients whose return to gainful employment is a primary rehabilitation goal, as it suggests that unaddressed depression at the outset of cardiac rehabilitation substantially diminishes the likelihood of achieving occupational recovery. The relationship between mood disturbance and workability is particularly relevant in cardiac rehabilitation, where the capacity to resume occupational activities is often a key determinant of long-term quality of life, financial stability, and psychosocial adjustment. Anxiety shapes rehabilitation outcomes in a pattern that's both related to and distinct from the effects of depression. Reductions in anxiety symptoms during the course of psychocardiological rehabilitation are associated with improvements in both work ability and quality of life. This suggests that anxiety may operate through pathways that are partially independent of those mediating the effects of depression, and that are particularly responsive to rehabilitation intervention. This differential pattern shows why it's important to assess and address both depression and anxiety as distinct but interrelated contributors to rehabilitation outcomes, rather than treating mood disturbance as a single construct. Clinicians who focus exclusively on depression may miss the independent contributions of anxiety to functional limitations and quality of life impairments. The AAOS Evidence-Based Clinical Practice Guideline further documents the pervasive impact of depression on patient-centered outcomes in orthopedic trauma rehabilitation, reporting that depression at multiple time points following injury is associated not only with decreased functional outcomes, but also with lower quality of life and reduced patient satisfaction. These findings are particularly important for contemporary rehabilitation practice because patient satisfaction and perceived quality of life are increasingly incorporated into quality reporting frameworks, value-based reimbursement models, and institutional accreditation standards. A rehabilitation program that achieves measurable improvements in physical function yet fails to address the psychological factors that diminish quality of life and satisfaction may fall short of the thorough, patient-centered care standards that define evidence-based rehabilitation practice. Having established the scope of these challenges, let's look at the encouraging side. Research demonstrates that targeted interventions can effectively reduce the impact of depression and anxiety on rehabilitation outcomes. This evidence demonstrates that depression and anxiety in rehabilitation aren't immutable barriers to recovery, but rather modifiable conditions whose treatment is directly linked to improved functional outcomes. That provides a strong rationale for integrating mental health interventions into rehabilitation programming. The American Heart Association and American Stroke Association guidelines for adult stroke rehabilitation note that pharmacological treatment of post-stroke depression can counterbalance its negative effects on functional recovery. Specifically, remission of depression, whether achieved through pharmacotherapy, psychotherapy, or combined approaches, is associated with greater recovery in activities of daily living. This establishes the clinical principle that treatment of depression in the rehabilitation context yields functional as well as psychological benefits. This guideline recommendation is particularly important because it reframes depression treatment in rehabilitation not as a side service tangential to the primary therapeutic goals, but as a direct and essential contributor to the physical rehabilitation outcomes that constitute the core mission of the interprofessional treatment team. Multidisciplinary rehabilitation approaches demonstrate similar promise in addressing the combined physical and psychological effects of acute medical events. In young and middle-aged patients with first-onset stroke, structured multidisciplinary rehabilitation is associated with substantial reductions in both depressive and anxiety symptoms, supporting the integration of psychological and psychiatric services within rehabilitation teams. These findings are especially noteworthy because they demonstrate the effectiveness of team-based approaches to mental health care in rehabilitation settings, extending the evidence base beyond the geriatric populations that have traditionally dominated the literature on depression and rehabilitation outcomes. The benefits of multidisciplinary intervention in younger stroke populations suggest that early coordinated intervention addressing both physical function and emotional well-being may optimize outcomes across the full age spectrum of rehabilitation patients. The evidence presented in this module establishes the clinical foundation for the mental health strategies examined throughout the remainder of this course. Depression and anxiety aren't peripheral concerns in physical rehabilitation. They're central, modifiable determinants of functional recovery that demand systematic assessment and evidence-based intervention from all members of the interprofessional rehabilitation team. The modules that follow will equip clinicians with specific strategies, including motivational interviewing, therapeutic alliance building, behavioral activation, and structured outcome measurement, to address these comorbidities within their scope of practice and across the diverse populations and settings in which rehabilitation care is delivered. Module 2 focuses on motivational interviewing in rehabilitation. Motivational interviewing, or MI, is a client-centered, directive method for enhancing intrinsic motivation and strengthening commitment for change through exploring and resolving ambivalence. Originally developed for the treatment of substance use disorders, MI has been increasingly adapted for use by rehabilitation professionals treating patients with depression or anxiety, clinical populations in which engagement barriers such as amotivation, resistance, and avoidance are pervasive and often constitute the primary obstacles to therapeutic progress. The foundational MI techniques, open-ended questioning, affirmations, reflective listening, and summarizing, collectively known by the acronym ORS, remain central to the MI approach in rehabilitation, but are tailored to address the unique needs and challenges of patients with comorbid mood and anxiety disorders. Each component of the ORS framework serves a distinct therapeutic function in the rehabilitation context. Open-ended questions are employed to understand the patient's values, priorities, and personal motivations regarding recovery, creating space for patients to articulate their own reasons for engaging in treatment, rather than responding passively to clinician directives. This technique is particularly valuable for patients with depression, whose diminished sense of agency and reduced capacity for self-directed behavior may cause them to disengage from the collaborative goal-setting processes that underpin effective rehabilitation. Affirmations reinforce the patient's efforts, strengths, and past successes, and that's especially important for individuals experiencing the low motivation, hopelessness, and diminished self-efficacy that characterize depressive disorders. By highlighting evidence of the patient's capacity for change, affirmations counter the negative cognitive patterns that depression imposes and help rebuild the sense of competence necessary for sustained engagement in therapeutic activities. Reflective listening, the third OARS component, validates the patient's emotional experience and restates opposing priorities or values in a manner that allows the patient to weigh the pros and cons of engaging in rehabilitation tasks. This approach is especially relevant for patients with anxiety who may be ambivalent about exposure-based or physically demanding interventions, as it acknowledges the legitimacy of the patient's fear or apprehension while gently directing attention toward the potential benefits of participation. Rather than confronting resistance directly, an approach that tends to increase defensiveness and reduce engagement, reflective listening creates a non-judgmental therapeutic space in which patients feel heard and understood. That enables a more open exploration of their ambivalence. Summarizing, the fourth component consolidates the discussion, clarifies goals, and confirms the treatment plan, thereby strengthening the therapeutic alliance and ensuring that clinician and patient share a common understanding of the path forward. The spirit of motivational interviewing, characterized by acceptance, partnership, evocation, and compassion, represents the relational foundation upon which specific MI techniques are deployed. This spirit aligns closely with recovery-oriented principles in mental health care and is emphasized in rehabilitation settings as a means of fostering partnership and patient autonomy. Acceptance involves meeting patients where they are without imposing judgment or expectations. Partnership frames the therapeutic relationship as a collaboration between equals rather than an expert-patient hierarchy. Evocation draws upon the patient's own motivations and values rather than imposing external reasons for change. And compassion prioritizes the patient's well-being as the fundamental purpose of the clinical encounter. When clinicians embody the spirit of MI consistently throughout their interactions, patients are more likely to perceive the therapeutic relationship as supportive, respectful, and empowering. These are conditions that are particularly conducive to engagement among individuals whose depression or anxiety has eroded their trust in healthcare providers or their confidence in their own capacity for recovery. A central therapeutic task in MI is the management of ambivalence, the simultaneous experience of competing motivations for and against behavioral change. This is a defining feature of many patients' experience during rehabilitation, particularly when comorbid depression or anxiety is present. Techniques such as rolling with resistance and developing discrepancy help patients articulate their reasons for and against change and highlight the gap between their current behaviors and their desired outcomes. Rather than arguing for change or attempting to persuade the patient through logic or authority, the MI-trained clinician allows the patient to explore both sides of the ambivalence, trusting that when patients examine their own values and priorities, they'll identify compelling personal reasons for engaging in treatment. This approach is especially effective with patients whose depression has fostered a sense of helplessness or whose anxiety has created rigid avoidance patterns, as it restores a sense of agency and self-determination that these conditions often erode. Developing discrepancy, a technique in which the clinician helps the patient recognize the distance between where they are and where they want to be, is particularly powerful in rehabilitation. The gap between current functional status and pre-injury or pre-illness capacity is often concrete, visible, and personally meaningful to the patient. When patients themselves articulate the consequences of remaining in their current state and voice their desire to regain lost function, the resulting motivation is far more durable than compliance driven by external pressure or professional recommendation. Expanding change talk, which refers to patient statements indicating a desire, ability, reason, or need for change, is a core MI skill that has been demonstrated to mediate treatment outcomes in clinical research. In a cluster randomized trial, Keeley and colleagues demonstrated that providers' ability to elicit change talk and direct discussions toward depression treatment mediated the effects of MI on depressive symptom improvement. MI-treated patients in this trial showed a moderate and statistically reliable improvement in depressive symptom reduction, a benefit that was consistent across the study population and unlikely to be due to chance, along with a 14.53% higher remission rate at 36 weeks compared to standard management alone. These findings provide direct evidence that the specific MI mechanism of eliciting change talk, rather than general supportive communication, is responsible for the observed therapeutic benefits. The magnitude of the treatment benefit and the substantial difference in remission rates are particularly meaningful in rehabilitation, where even modest improvements in depressive symptoms can translate into clinically significant gains in functional participation, treatment adherence, and quality of life. These data support the targeted training of rehabilitation professionals in the skill of eliciting change talk as a high-yield clinical competency with demonstrated efficacy in reducing depressive symptoms and improving treatment engagement. The meta-analytic literature, research that statistically combines findings from multiple independent studies, provides further support for the effectiveness of MI in managing ambivalence across mental health populations. Romano and Peters found that MI demonstrated a significant positive effect on patient engagement variables in mental health populations, with the effect most pronounced in anxiety, mood, and psychotic disorders. Lawrence and colleagues found that MI delivered as a pre-treatment intervention improved attendance relative to comparison groups, with the greatest benefit observed in individuals who are not actively seeking treatment, precisely the population most likely to present with ambivalence and resistance in rehabilitation settings. Here's a key finding. Short MI interventions consisting of as few as 2 sessions totaling 15 minutes were found to be as effective as longer interventions for enhancing treatment attendance. That suggests MI can be feasibly integrated into the time-constrained clinical encounters characteristic of rehabilitation practice. The application of MI extends beyond its use as an engagement and motivational enhancement strategy to encompass the goal setting and treatment planning processes that are central to rehabilitation care. MI has been integrated into rehabilitation goal-setting processes with promising results, offering a framework for collaborative treatment planning that aligns therapeutic objectives with patient values and priorities. A 2025 feasibility study by Wintle and colleagues demonstrated that MI-based goal-setting sessions, conducted with a median duration of 20 minutes, were both feasible and acceptable to patients and clinicians in a rehabilitation setting, with 86% uptake among eligible patients and 69% of patient-centered goals achieved at discharge. These feasibility data are clinically important because they demonstrate that MI-based goal setting can be implemented within the existing structure and time constraints of rehabilitation practice without requiring substantial reorganization of clinical workflows. The high rate of goal achievement, nearly 7 in 10 patient-centered goals met by discharge, suggests that when patients are active participants in defining their own rehabilitation objectives, their investment in working toward those objectives is substantially enhanced compared to traditional clinician-directed goal-setting approaches. The collaborative nature of MI-based goal setting is consistent with the broader shift in rehabilitation medicine toward patient-centered care models that prioritize the patient's own values, preferences, and functional priorities. By using open-ended questions and reflective listening to explore what matters most to the patient, rather than imposing standardized goals derived solely from clinical assessment, trained clinicians can develop treatment plans that are both clinically sound and personally meaningful. This alignment between clinical goals and personal values is particularly important for patients with depression, whose diminished motivation and sense of purpose may make it difficult to engage with goals that feel externally imposed or disconnected from their lived experience. Setting open, explorative goals collaboratively, for example, framing objectives as "see how active you can be this week" rather than prescribing specific performance targets, respects patient autonomy while maintaining therapeutic direction. The timing and delivery pattern of MI within rehabilitation care is an important consideration for clinical implementation. The evidence supports intermittent delivery of MI throughout the course of therapy, rather than its use as a single pre-treatment intervention, as the approach most likely to produce sustained improvements in engagement and outcomes. Marker and colleagues found in a randomized controlled trial that integrating 1 hour of MI spread across 4 sessions of transdiagnostic cognitive behavioral therapy, or CBT, approximately 15 minutes per session, significantly outperformed CBT with psychoeducation on self-report symptom improvement and clinician-rated global psychiatric functioning. The accompanying meta-analysis reported a medium-sized and clinically meaningful treatment benefit for MI combined with CBT versus CBT alone in the treatment of anxiety disorders, one that is both statistically significant and practically relevant for clinical decision-making. These findings indicate that brief, strategically timed MI interventions can meaningfully enhance the outcomes of evidence-based psychotherapeutic approaches without requiring substantial additional treatment time. The intermittent delivery model is particularly well-suited to rehabilitation, where patients are seen repeatedly over days or weeks, and where motivation may fluctuate in response to pain, fatigue, setbacks in functional progress, or the cumulative psychological burden of prolonged treatment. By embedding MI throughout the therapeutic course, rather than concentrating it at intake, clinicians can address motivational challenges as they arise in real time, maintaining the patient's engagement through the inevitable ups and downs of the recovery process. The integration of MI with CBT is supported by a compelling theoretical rationale. MI addresses the motivational and engagement barriers that may prevent patients from fully participating in the cognitive and behavioral change processes that CBT requires, while CBT provides the structured skill-building and exposure-based interventions that produce lasting symptom reduction. In a 3-arm randomized controlled trial examining MI combined with CBT versus non-directive counseling, combined with CBT versus waitlist control in patients with traumatic brain injury, both active treatment groups showed significantly greater reduction in anxiety and depression symptoms compared to the waitlist condition. However, MI combined with CBT didn't confer additional benefit over non-directive counseling combined with CBT in this specific population. This suggests that the relational and supportive elements common to both MI and non-directive counseling may be the primary active ingredients in enhancing CBT outcomes for patients with acquired brain injury. This finding doesn't diminish the value of MI, but rather highlights the importance of the therapeutic relationship, a theme explored in depth in Module 3, as a mechanism through which engagement-focused interventions produce their effects. The evidence reviewed in this module supports a systematic approach to integrating MI into routine rehabilitation practice. Rehabilitation professionals should assess the patient's readiness to change at the initial encounter, use OARS skills to explore ambivalence and elicit change talk throughout the course of treatment, and set open, explorative goals collaboratively with patients. Brief MI sessions of 15 to 20 minutes delivered intermittently throughout rehabilitation, particularly at points where resistance arises or motivation wanes, represent an evidence-based delivery format that's compatible with the time constraints and clinical demands of rehabilitation settings. Clinicians should combine MI with behavioral activation, CBT, or acceptance and commitment therapy based on patient preference and cognitive capacity, and involve family members and caregivers in the MI process, especially when working with geriatric and home care populations. Ongoing training, supervision, and fidelity monitoring for all clinicians delivering MI are essential to ensure that the techniques are implemented with the consistency and quality required to produce meaningful clinical outcomes. These implementation recommendations are supported by clinical trials, systematic reviews, and practice guidelines from the Department of Veterans Affairs, the American Psychological Association, the American Society of Clinical Oncology, and the American Academy of Pediatrics. The breadth of organizational endorsement for MI across these diverse clinical domains reflects the strength of the evidence base and the adaptability of MI techniques to the varied contexts in which rehabilitation professionals deliver care. As subsequent modules will demonstrate, MI functions most effectively as one component of a thorough, interprofessional approach to mental health in rehabilitation, an approach that also encompasses the therapeutic alliance, behavioral strategies, population-specific adaptations, and structured outcome measurement. Module 3 examines the therapeutic alliance and its influence on rehabilitation outcomes. The therapeutic alliance, the collaborative and affective bond between clinician and patient, has emerged as one of the most consistently documented predictors of treatment outcomes across psychotherapeutic modalities. It has particular relevance for rehabilitation populations in whom comorbid depression and anxiety compromise engagement and functional recovery. Understanding the nature, strength, and clinical significance of the Alliance outcome relationship provides rehabilitation professionals with a conceptual framework for recognizing why the quality of the clinician-patient relationship isn't merely a desirable interpersonal attribute, but a measurable, evidence-based contributor to the functional and psychological outcomes that define successful rehabilitation care. The Therapeutic Alliance is independently and moderately associated with improved rehabilitation outcomes, including functional recovery and treatment adherence in patients with depression or anxiety. This association persists after controlling for baseline symptom severity and early symptom change. The quantitative evidence linking Alliance quality to treatment outcomes in depression is strong and consistent. A meta-analysis of cognitive behavioral therapy for adults with depression found a moderate and statistically reliable relationship between Alliance quality and treatment outcomes, a finding that is remarkably consistent and has been replicated across other psychotherapeutic modalities and patient populations. This relationship is clinically meaningful because it demonstrates that the quality of the working relationship between clinician and patient accounts for a measurable proportion of the variance in depressive symptom outcomes, independent of the specific therapeutic techniques employed. Critically, this relationship persists after adjusting for baseline symptom severity and early symptom change, with the adjusted relationship remaining moderate and stable even after applying these rigorous statistical controls. This confirms that the Alliance is an independent process-based factor rather than an epiphenomenon, a secondary byproduct of early improvement or a reflection of patients who are already getting better, forming stronger bonds with their clinicians. The consistency of this adjusted effect across multiple studies strengthens the conclusion that the Alliance is an independent predictor of outcomes, rather than serving as a proxy for other prognostic variables. For rehabilitation professionals, these findings carry immediate clinical implications. The relational quality of every therapeutic encounter contributes measurably to the depressive symptom outcomes that shape patients' capacity for functional participation and recovery. The temporal dynamics of the Alliance outcome relationship provide additional clinical guidance for rehabilitation professionals. The Alliance, particularly as measured early in treatment by the third or fourth session, is a strong predictor of subsequent therapeutic outcomes. A detailed literature review of the effects of Therapeutic Alliance on patients with major depressive disorder confirmed that early Alliance quality is among the strongest and most reliable predictors of symptom trajectory and treatment response. This supports the clinical principle that the first 3 to 4 sessions of any therapeutic encounter represent a critical window for establishing the relational foundation upon which effective treatment is built. The World Psychiatric Association has emphasized the Alliance as a key determinant of outcome in mental health care, noting its applicability across diverse treatment contexts, including rehabilitation settings where patients present with comorbid psychological and physical health challenges. These converging lines of evidence establish that the Therapeutic Alliance isn't a peripheral or secondary element of clinical practice, but rather a fundamental mechanism through which treatment effects are produced and sustained. For rehabilitation clinicians, the clinical implication is that a deliberate, sustained investment in the quality of the clinician-patient relationship during the first several sessions of treatment isn't time taken away from functional interventions. It's a prerequisite for maximizing the effectiveness of every subsequent therapeutic encounter. The mechanisms by which the Therapeutic Alliance exerts its effects on treatment outcomes encompass both direct and indirect pathways, each of which has particular relevance for rehabilitation professionals working with patients whose depression or anxiety compromises their capacity to engage in therapeutic activities that drive functional recovery. Directly, a strong alliance fosters patient engagement, trust, and willingness to participate in challenging rehabilitation tasks. These are qualities essential for patients whose mood disturbance manifests as a motivation, hopelessness, or avoidance of physically and emotionally demanding interventions. Indirectly, the alliance enhances emotion regulation, self-efficacy, and problem clarification, which mediate symptom reduction and functional gains. Understanding these mechanisms is essential for rehabilitation professionals because it transforms the alliance from an abstract relational concept into a set of identifiable, clinically actionable processes that can be deliberately cultivated through specific clinician behaviors and communication strategies. The mediating role of emotion regulation in the alliance outcome relationship has been demonstrated with particular clarity in the treatment of adolescent depression. In a study of internet-based treatments for adolescent depression, Linkevist and colleagues found that alliance ratings predicted improvements in emotion regulation, which in turn predicted reductions in depressive symptoms. This supports a mediational model in which the alliance operates on outcomes through its effects on the patient's capacity to manage and modulate emotional distress. The investigators describe this as the alliance being both calming and curing. Calming in its direct provision of emotional support and security within the therapeutic relationship, and curing through its enabling of the emotion regulation skills that help patients manage depressive symptoms more effectively over the course of treatment. For rehabilitation professionals, this finding suggests that the quality of the clinician-patient relationship doesn't simply make patients feel better in the moment. It equips them with the psychological resources necessary to sustain engagement and manage the emotional challenges of the recovery process over time. The role of mastery and self-efficacy as mediators of the alliance outcome link has been examined in intensive inpatient treatment for depression. Schwartz and colleagues demonstrated that within-person changes in alliance quality preceded and partially mediated symptom change via increased mastery and self-efficacy in patients undergoing intensive inpatient cognitive behavioral therapy for depression. This temporal sequence, in which alliance improvement leads to increased mastery, which in turn leads to symptom reduction, is particularly informative for rehabilitation settings. It suggests that the alliance operates by fostering patients' sense of competence and agency, qualities that are directly relevant to the functional tasks and challenges that characterize rehabilitation care. Patients who develop a strong working alliance with their rehabilitation clinician may be more likely to attempt challenging activities, persist through setbacks, and develop confidence in their capacity for recovery, all of which contribute to the functional gains that define successful rehabilitation treatment. Taken together, these findings from both adolescent and adult treatment contexts reveal that the alliance isn't a unitary construct operating through a single pathway. Rather, it's a relational process with multiple dimensions that enhances outcomes through complementary mechanisms, emotional support and regulation on one hand, and the cultivation of competence and mastery on the other. Rehabilitation professionals who understand these mechanisms can be more intentional in their relational practice, recognizing that each therapeutic interaction offers an opportunity to strengthen both the emotional security and the self-efficacy of patients whose depression or anxiety has compromised both. The relevance of the therapeutic alliance extends beyond the psychotherapy literature to encompass physical rehabilitation itself, where the clinician-patient relationship has been shown to influence a range of outcomes that are central to the rehabilitation mission. A systematic review by Hall and colleagues found that the therapeutic alliance is positively associated with treatment adherence, depressive symptoms, treatment satisfaction, and physical function across diverse patient populations, including those with brain injury, musculoskeletal conditions, cardiac conditions, and geriatric rehabilitation needs. This breadth of evidence across diagnostic categories and treatment settings reinforces the conclusion that the alliance isn't a phenomenon confined to mental health treatment. It operates as a universal contributor to positive outcomes wherever a clinician and patient work together towards shared therapeutic goals. The magnitude of the alliance's contribution to treatment outcomes has been characterized in authoritative clinical guidelines. The American Psychological Association, in its 2021 Guidelines on Evidence-Based Psychological Practice in Healthcare, draws on a meta-analytic decomposition of the depression treatment literature to estimate that approximately half of patient improvement can be attributed to common factors, including the alliance, approximately one-third to extra therapeutic factors, such as spontaneous remission, and only about one-sixth attributable to specific therapeutic techniques. While these proportions remain debated in the psychotherapy research community and should be interpreted as approximations rather than precise figures, the disparity between the contributions of the therapeutic relationship and specific techniques has implications for rehabilitation practice. It suggests that how clinicians interact with their patients may be at least as important as the particular interventions they employ. In a foundational 1996 study from the National Institute of Mental Health Treatment of Depression Collaborative Research Program, a secondary analysis of 225 depressed outpatients across 619 rated therapy sessions, Krupnik and colleagues demonstrated that the therapeutic alliance had a significant effect on clinical outcome across all 4 treatment conditions: interpersonal psychotherapy, cognitive behavioral therapy, imipramine with clinical management, and placebo with clinical management. The patient's contribution to the alliance was significantly related to treatment outcome, regardless of the treatment modality received. This is particularly noteworthy because it demonstrates that the alliance influences outcomes not only in psychotherapeutic contexts, but also in pharmacological treatment, suggesting that the quality of the clinician-patient relationship permeates all aspects of care and can't be dismissed as relevant only to talk-based therapeutic approaches. For rehabilitation professionals, the NIMH findings reinforce the principle that every clinician who interacts with the patient, whether providing physical therapy, occupational therapy, nursing care, or medical management, contributes to the overall alliance experience that shapes treatment outcomes. The alliance isn't the exclusive domain of mental health specialists. It's a shared responsibility of the entire interprofessional team. The application of alliance-building principles varies meaningfully across different patient populations, and rehabilitation professionals must adapt their relational strategies accordingly. Meta-analytic evidence demonstrates that certain clinician behaviors can actively strengthen or damage the therapeutic relationship. The negative impact of alliance-reducing behaviors, such as dismissiveness, rigidity, and failure to validate the patient's emotional experience, exceeds the positive effect of explicitly supportive behaviors. This principle applies across all age groups and clinical settings. What's more, the mechanisms through which the alliance influences outcomes shift across the lifespan. While emotion regulation pathways predominate in younger populations, trust and perceived competence are central to alliance-driven engagement in geriatric rehabilitation. These population-specific differences in alliance formation and function, including the specific clinician behaviors, developmental considerations, and relational strategies required for effective alliance building across adolescent, adult, and geriatric populations, are examined in detail in Module 5. The evidence reviewed in this module establishes the therapeutic alliance as a critical, measurable, and modifiable contributor to rehabilitation outcomes for patients with comorbid depression and anxiety. Rehabilitation professionals who invest in building and maintaining strong alliances through empathic communication, collaborative goal setting, and consistent attention to the patient's emotional experience aren't engaging in ancillary interpersonal niceties. They're deploying an evidence-based strategy with demonstrated effects on treatment adherence, symptom reduction, and functional recovery. As subsequent modules will demonstrate, the alliance functions synergistically with the motivational interviewing techniques and behavioral strategies discussed elsewhere in this course, forming part of a thorough, interprofessional approach to addressing mental health challenges in rehabilitation settings. Module 4 addresses behavioral strategies for Amotivation and Avoidance. As established in the course introduction and Module 1, the Amotivation associated with depression and the avoidance driven by anxiety constitute major barriers to rehabilitation engagement. Effectively addressing these barriers requires integrating behavioral, psychotherapeutic, and physical activity strategies into a cohesive treatment approach. Among the available behavioral approaches, behavioral activation, or BA, a structured therapeutic approach that targets the cycle of withdrawal and inactivity, maintaining depression by systematically scheduling valued activities, has garnered substantial empirical support as a first-line intervention for depression. It carries particular advantages for rehabilitation populations in whom cognitive demands, physical limitations, and comorbid medical conditions may constrain the use of more cognitively intensive psychotherapeutic approaches. The Department of Veterans Affairs Clinical Practice Guideline for Major Depressive Disorder recommends behavioral activation as a first-line psychotherapy, emphasizing its value in increasing activity levels and improving mood through structured practice, mood tracking, and functional analysis of barriers to engagement. The rationale for this recommendation reflects BA's theoretical foundation. Depression is maintained in part by a cycle of withdrawal and inactivity that reduces exposure to positive reinforcement. BA disrupts this cycle by systematically scheduling activities that are consistent with the patient's values and goals, using 3 core components: activity scheduling, mood monitoring, and functional analysis of behavioral barriers. This mechanism is directly applicable to rehabilitation, where the physical inactivity and social withdrawal associated with depression can compound the functional limitations imposed by the patient's medical condition, creating a self-reinforcing cycle of deconditioning, despair, and progressive functional decline. The structured nature of BA, with its emphasis on activity scheduling, mood monitoring, and systematic identification of behavioral barriers, aligns naturally with the goal-oriented, task-specific structure of rehabilitation programming. That makes BA one of the most implementation-ready psychotherapeutic approaches available for rehabilitation settings. The comparative effectiveness of behavioral activation relative to other evidence-based psychotherapies has been examined in rehabilitation-specific contexts. In a quasi-randomized controlled study by Melicherova and colleagues, both BA and cognitive behavioral therapy produced large and clinically meaningful reductions in depressive symptoms as measured by the Beck Depression Inventory 2 at end of treatment, and those substantial improvements were maintained or strengthened at follow-up. There was no statistically significant difference between the two modalities, and at least 50% symptom reduction was achieved by approximately 54% of patients in both groups. These findings carry significant implications for rehabilitation practice because BA requires fewer cognitive resources than traditional CBT. That makes it more accessible for patients with cognitive impairments, fatigue, or limited attention, characteristics that are common in many rehabilitation populations, including those recovering from stroke, traumatic brain injury, or complex medical illness. Network meta-analyses of BA, cognitive restructuring, and CBT have further confirmed that there's no evidence of differential effectiveness among these three treatments, all of which are superior to care as usual and waiting list controls. A meta-analysis by Stein and colleagues specifically examining the effect of behavioral activation found benefits that extended beyond depression to include reductions in anxiety and improvements in behavioral activation levels. This suggests that BA addresses the transdiagnostic processes of avoidance and inactivity that characterize both depressive and anxiety disorders. The transdiagnostic reach of BA is particularly valuable in rehabilitation settings, where depression and anxiety frequently co-occur and where a single intervention capable of addressing both conditions simultaneously offers substantial practical and clinical advantages over approaches that require separate treatment protocols for each disorder. While behavioral activation offers a compelling first-line option, rehabilitation professionals should be aware of the full spectrum of evidence-based psychotherapies available for addressing depression in their patient populations. A thorough review published in JAMA by Simon and colleagues summarized first-line psychotherapies for depression, including cognitive behavioral therapy, behavioral activation, interpersonal therapy, problem-solving therapy, short-term psychodynamic psychotherapy, and mindfulness-based therapies. All of these modalities demonstrated medium to large treatment benefits, corresponding to typical response rates of 50% with psychotherapy, compared to 25% without active treatment. The breadth of effective options is clinically important because it provides rehabilitation teams with the flexibility to match therapeutic approaches to individual patient needs, preferences, and cognitive capacities. A principle of patient-centered care that's consistent with the collaborative, values-based approach to treatment planning discussed in Module 2. The finding that approximately half of patients respond to psychotherapy compared to 1/4 who improve without active treatment provides a compelling evidence-based rationale for ensuring that rehabilitation patients with comorbid depression have access to structured psychotherapeutic intervention, whether delivered by embedded mental health professionals, trained rehabilitation clinicians, or through referral to community providers. The American Society of Clinical Oncology guideline further extends the evidence base by recommending CBT, acceptance and commitment therapy, and mindfulness-based stress reduction for managing both depression and anxiety in adult cancer survivors. This guideline is particularly relevant for rehabilitation professionals because cancer survivors represent a growing proportion of the rehabilitation population, and the comorbid mood and anxiety disorders that frequently accompany cancer diagnosis and treatment can substantially compromise rehabilitation engagement and functional recovery. Meta-analyses summarized within this guideline report moderate to large reductions in depression and some reduction in anxiety with exercise interventions, establishing physical activity as an important adjunctive strategy that can be integrated with psychotherapeutic approaches to produce synergistic benefits. The inclusion of acceptance and commitment therapy, or ACT, in these guideline recommendations is noteworthy because ACT's emphasis on psychological flexibility, acceptance of difficult emotions, and values-based action is particularly well suited for rehabilitation patients who may struggle with grief over lost function, fear of re-injury, or frustration with the pace of recovery. ACT addresses these emotional experiences directly through its acceptance and commitment framework, rather than attempting to eliminate or restructure them. Building on the psychotherapeutic approaches described above, physical activity integration represents a particularly strategic intervention for rehabilitation populations because it simultaneously addresses the physical deconditioning and psychological distress that frequently coexist in patients with comorbid depression or anxiety. The evidence supporting the antidepressant effects of exercise is substantial. Recent meta-analyses report moderate to large treatment benefits. The 2026 Cochrane Review reports a moderate to large benefit for exercise in improving depressive symptoms, and even when the analysis is limited to only the most rigorously designed high-quality trials, the benefit remains at least moderate and is statistically reliable. These treatment benefits are clinically meaningful and comparable to those reported for pharmacological and psychotherapeutic interventions, positioning exercise as a credible adjunctive or standalone intervention for depression in rehabilitation contexts, where patients are already engaged in structured physical activity programs. The dual benefit of exercise, simultaneously improving physical function and reducing depressive symptoms, makes physical activity integration one of the most efficient therapeutic strategies available to rehabilitation teams. It allows clinicians to advance both rehabilitative and mental health objectives within a single treatment session without requiring additional time or separate intervention protocols. The practical implementation of physical activity as an antidepressant intervention requires specific clinical strategies that address the barriers to exercise participation posed by depression-related amotivation and anxiety-driven avoidance. Practical clinical recommendations published in JAMA Psychiatry by Stubbs and colleagues advocate for open explorative goals, such as see how active you can be this week, rather than rigid performance targets that may feel overwhelming to patients whose depression has compromised their motivation and self-efficacy. Additional recommended strategies include mental contrasting with implementation intentions, a technique in which patients are guided to visualize their desired outcome and then identify and plan for potential obstacles. Supervised physical activity sessions that provide structure and accountability, and a focus on modifying one behavior at a time for sedentary or highly emotivated patients. These practical strategies are directly applicable to rehabilitation settings, where clinicians have the advantage of regular face-to-face contact with patients and the ability to embed physical activity goals within the broader rehabilitation treatment plan. The emphasis on open, explorative goals is consistent with the motivational interviewing approach discussed in Module 2, reinforcing the principle that patient autonomy and self-directed goal attainment produce more durable behavioral change than externally imposed performance expectations. Beyond the foundational behavioral and physical activity strategies discussed in the preceding sections, several additional modalities offer promising avenues for addressing amotivation and avoidance in rehabilitation populations. Occupational therapy interventions incorporating cognitive and behavioral strategies have shown moderate efficacy in addressing depressive and anxiety symptoms and improving participation in inpatient rehabilitation. A systematic review by Pizzegna and colleagues is particularly relevant because it focuses specifically on the physical disability inpatient rehabilitation setting, providing evidence that occupational therapy-based interventions can serve as a vehicle for delivering behavioral strategies within the existing structure of rehabilitation care without requiring additional staffing or programmatic changes. This finding supports the interprofessional approach emphasized throughout this course, demonstrating that mental health interventions in rehabilitation need not be confined to psychologists or psychiatrists. They can be effectively integrated into the clinical practice of rehabilitation professionals, including occupational therapists, physical therapists, and nurses, working within their existing scope of practice. Technology-assisted interventions represent an emerging frontier in the delivery of behavioral activation and related strategies. Computer-delivered behavioral activation and approach avoidance training have demonstrated feasibility and a large, clinically meaningful reduction in depressive symptoms, with an 80% treatment completion rate. The magnitude of this treatment benefit and the high completion rate suggest that technology-assisted BA may be particularly well-suited for patients who face barriers to traditional face-to-face psychotherapy, including those in rural or underserved settings, those with mobility limitations that restrict access to clinic-based services, or those whose rehabilitation schedules create logistical challenges for accessing mental health providers. However, the proof-of-concept nature of this evidence warrants cautious interpretation, and further research in rehabilitation-specific populations is needed before widespread clinical implementation can be recommended. The high completion rate is nonetheless encouraging, as treatment dropout is a significant challenge in depression intervention research. The finding that 80% of participants completed the computer-delivered protocol suggests that the technology-assisted format may reduce some of the barriers such as stigma, scheduling difficulties, and transportation challenges that contribute to attrition in traditional face-to-face treatment. Guided self-help represents another evidence-based approach that offers practical advantages in time-constrained rehabilitation settings. Research has demonstrated that both guided self-help BA and physical activity interventions are significantly more effective than waitlist control in reducing depressive symptoms. An important finding from this research is that physical activity requires less than half the time investment of guided self-help BA while producing comparable reductions in depressive symptoms. So for patients and clinical settings where time is a limiting factor, physical activity may represent a particularly efficient means of delivering behaviorally based depression intervention. This has direct implications for rehabilitation practice, where the availability of structured physical activity programming creates a natural opportunity to achieve both rehabilitative and antidepressant objectives through a single, integrated intervention approach. The comparative efficiency of physical activity as a depression intervention, requiring substantially less clinician time than guided self-help BA while producing comparable symptom reduction, is an important consideration for rehabilitation settings where clinician time is a scarce resource and where competing clinical demands may limit the feasibility of time-intensive psychotherapeutic approaches. The implementation of behavioral strategies in clinical practice is aided by attention to the barriers and facilitators that have been identified in the research literature. The most common barriers to implementing behavioral strategies, motivational interviewing, and alliance building in rehabilitation include patient ambivalence and resistance, clinician discomfort and lack of training in mental health approaches, time constraints, limited mental health resources, and environmental challenges in the clinical setting. Key facilitators include patient-centered communication, collaborative goal setting, motivational interviewing training with ongoing supervision, efficient delivery processes, and compassionate engagement established after initial rapport has been built. Training programs that combine classroom instruction with ongoing coaching and feedback are more effective in enhancing clinicians' ability to deliver motivational and behavioral interventions than training programs that exclude these components. This highlights the need for institutional investment in sustained professional development rather than one-time workshop-based training. By attending to both the evidence base for specific interventions and the implementation science that governs their successful adoption, rehabilitation teams can build thorough, sustainable programs for addressing the amotivation and avoidance that compromise recovery in patients with comorbid depression and anxiety. Module 5 examines how the motivational interviewing techniques, therapeutic alliance strategies, and behavioral approaches discussed in preceding modules require systematic adaptation when applied to different developmental populations and clinical settings. The evidence base consistently demonstrates that a one-size-fits-all approach to mental health intervention in rehabilitation is neither clinically appropriate nor therapeutically effective. The specific clinician behaviors, communication strategies, and intervention formats that optimize outcomes vary meaningfully across adolescent, adult, and geriatric populations and across inpatient, outpatient, and home care environments. This module examines the evidence for population-specific and setting-specific adaptations, providing rehabilitation professionals with the knowledge needed to tailor their approach to the unique needs, developmental capacities, and contextual demands of each patient they serve. Adolescents represent a developmentally distinct population in rehabilitation for whom standard adult-oriented MI and alliance-building strategies must be carefully modified. This accounts for the cognitive, emotional, and social characteristics of this age group. Research on MI with youth, including the National Institute on Alcohol Abuse and Alcoholism's Practitioner's Guide, highlights that MI is particularly well suited for adolescent populations because it avoids confrontation, respects individuality, and supports the autonomy that is central to healthy adolescent development. These characteristics are especially important in rehabilitation contexts, where adolescents may experience the loss of physical function, social disruption, and dependency on adults as particularly threatening to their emerging sense of identity and independence. The American Academy of Pediatrics extends this framework by recommending that clinicians assess readiness to change and tailor anticipatory guidance to the adolescent stage of change using MI's 4 processes: engaging, focusing, evoking, and planning. This structured yet flexible approach provides a developmentally appropriate framework for working with adolescents, whose ambivalence about treatment participation may reflect normative developmental processes, such as identity exploration and resistance to adult authority, in addition to the depression or anxiety-related motivational barriers that affect patients across the age spectrum. The empirical evidence supporting MI as a pre-treatment engagement strategy for adolescents with mental health conditions is compelling. A randomized clinical trial by Dean and colleagues demonstrated that MI delivered as a pre-treatment intervention significantly increased group therapy session attendance, treatment initiation, and treatment readiness ratings in adolescents with anxiety and mood disorders compared to an active control condition consisting of befriending. These findings are particularly relevant for rehabilitation professionals because treatment engagement, the patient's willingness to attend sessions, participate actively, and follow through with therapeutic recommendations, is the foundational prerequisite for all other interventions discussed in this course. An adolescent who doesn't attend or participate meaningfully in rehabilitation can't benefit from the behavioral activation, physical activity integration, or alliance-building strategies that produce functional improvement. That makes pre-treatment engagement a clinical priority of the highest order. Alliance building with adolescent clients requires a distinct set of clinician behaviors that differ in important ways from those that are effective with adult populations. A systematic review and meta-analysis by Orlowski and colleagues identified specific clinician behaviors associated with alliance formation in youth, including collaboration, finding common ground, exploring subjective experiences, and providing praise, with a statistically significant positive effect of these behaviors on therapeutic outcomes. Equally important, the meta-analysis identified alliance-reducing behaviors, such as being overly directive, dismissive of the patient's perspective, or failing to acknowledge the patient's emotional experience. And the damaging impact of these negative behaviors was found to be substantially larger than the positive effect of constructive alliance-building behaviors. The asymmetry between these effects carries a critical clinical implication. For rehabilitation professionals working with adolescents, avoiding behaviors that damage the alliance may be even more important than engaging in explicitly supportive behaviors. Clinicians who adopt an authoritarian communication style, minimize the adolescent's subjective experience of pain or distress, or fail to involve the patient in treatment decisions risk undermining the therapeutic relationship to a degree that may compromise the effectiveness of every subsequent intervention. For adult rehabilitation populations, the adaptation of MI and related strategies centers on integrating these approaches within the time-constrained clinical encounters and medically involved treatment environments that characterize most adult rehabilitation care. In adults, MI has been shown to be effective in brief encounters as short as 15 minutes, with follow-up visits enhancing effectiveness. This finding is practically important because it demonstrates that MI can be feasibly delivered within the typical duration of a rehabilitation therapy session without requiring dedicated additional time or separate appointments, a critical consideration for implementation in settings where clinician time is a scarce and contested resource. The effectiveness of brief MI encounters in adult populations reflects the concentrated therapeutic impact of even short interactions when those interactions are conducted with fidelity to MI principles, including the consistent use of OARS techniques, attention to the patient's stage of change, and deliberate elicitation of change talk as described in Module 2. Brief action planning, or BAP, has emerged as a particularly effective adjunct to MI for adult rehabilitation patients, providing a structured framework for translating the motivational gains achieved through MI into concrete, measurable behavioral commitments. BAP integrates collaborative SMART goals, specific, measurable, achievable, relevant, and time-bound objectives, with confidence scaling and problem-solving to reduce barriers and strengthen the therapeutic alliance. The confidence scaling component of BAP is especially valuable in rehabilitation, as it provides clinicians with a real-time assessment of the patient's self-efficacy regarding specific therapeutic tasks, allowing the clinician to calibrate the difficulty of assigned activities to a level that challenges the patient without exceeding their perceived capacity for success. When a patient rates their confidence in completing a planned activity below a predetermined threshold, typically 7 out of 10, the clinician and patient collaboratively problem-solve to identify and address the specific barriers reducing confidence, whether those barriers are physical, psychological, logistical, or environmental in nature. This systematic approach to identifying and addressing barriers is consistent with the behavioral activation principles discussed in Module 4 and provides a practical structure for translating those principles into individualized treatment plans. The integration of BAP with MI creates a seamless clinical workflow in which the motivational groundwork established through MI is immediately channeled into specific, achievable behavioral commitments that advance the patient's rehabilitation goals while simultaneously addressing the amotivation and avoidance that accompany comorbid depression and anxiety. Geriatric rehabilitation populations present a unique set of challenges that require specific adaptations to the MI, alliance building, and behavioral strategies discussed in preceding modules. Cognitive and sensory impairments represent the most prominent barriers to MI implementation in older adults, requiring simplified language, slower pacing, and the use of assistive devices to ensure that patients can fully engage in the motivational and collaborative processes that MI requires. Rehabilitation professionals working with geriatric patients must be prepared to modify their communication style substantially, using shorter sentences, repeating key information, providing written or visual supplements to verbal instructions, and allowing additional processing time, without sacrificing the patient-centered, non-authoritarian spirit that defines MI. The challenge lies in adapting the format of MI delivery while preserving its essential content and relational quality, ensuring that accommodations for cognitive or sensory limitations don't inadvertently create a paternalistic dynamic that undermines the patient's sense of agency and autonomy. The evidence for MI's effectiveness in improving therapeutic adherence among older adults is encouraging. A cluster randomized clinical trial by Morale and colleagues found that MI improved therapeutic adherence in patients over 65 years old with chronic diseases, with the MI group demonstrating nearly threefold higher odds of treatment adherence compared to an advice-based approach, a statistically significant finding. This nearly threefold increase in the odds of treatment adherence is clinically meaningful because non-adherence to rehabilitation recommendations, including exercise programs, medication regimens, and activity modifications, is a pervasive and consequential problem in geriatric rehabilitation that substantially limits functional outcomes. The finding that MI outperforms advice-based approaches is particularly instructive, as it demonstrates that simply telling older patients what they should do is far less effective than engaging them in a collaborative exploration of their own motivations, values, and barriers to action. As introduced in Module 3, the Therapeutic Alliance takes on a distinctive character in geriatric rehabilitation, operating primarily through mechanisms of trust and perceived competence. Qualitative research in older adults undergoing rehabilitation after hip fracture found that trust in the therapist's abilities and the feeling of mutuality and respect were central to motivation and engagement in the rehabilitation process. For geriatric patients, the alliance appears to function less through the emotion regulation and self-efficacy pathways emphasized in the adolescent and adult literature and more through a mechanism of trust-based security. Patients who believe their therapist is both technically skilled and genuinely invested in their well-being demonstrate greater willingness to endure the physical discomfort and psychological vulnerability inherent in post-fracture rehabilitation. This finding suggests that for geriatric populations, demonstrated clinical competence and consistent expressions of respect and genuine concern may be the most effective alliance-building strategies available to rehabilitation professionals. The emphasis on trust and mutuality in geriatric populations also has implications for the structure of rehabilitation teams, as older adults may respond more favorably to consistent assignment of the same therapist throughout their course of care, rather than rotating clinician assignments that prevent the development of the deep, trust-based relationships that drive engagement in this population. Taken together, the population-specific evidence across adolescent, adult, and geriatric groups reinforces the principle that effective mental health intervention in rehabilitation isn't defined by a universal protocol, but rather by the clinician's capacity to adapt evidence-based strategies to the developmental, cognitive, and relational characteristics of each individual patient. The implementation of mental health strategies in rehabilitation is significantly influenced by the characteristics of the clinical setting in which care is delivered, and rehabilitation professionals must adapt their approach to account for the structural, environmental, and logistical features of each context. In inpatient rehabilitation, MI and alliance building must account for the intensity of medical interventions, frequent care transitions, limited privacy, and the disruption to patients' normal routines and social networks that characterize the hospital environment. A pilot study by Bunyan and colleagues demonstrated that training inpatient rehabilitation nurses in MI was both feasible and relevant to clinical practice, with potential improvements in patient experience. This is significant because it establishes that MI can be effectively delivered by members of the rehabilitation team beyond mental health specialists, in this case nurses, who typically have frequent and sustained contact with inpatients, suggesting that MI training is applicable across rehabilitation disciplines. In stroke rehabilitation specifically, weekly MI sessions over 6 weeks significantly enhanced motivation for rehabilitation compared to attention control, with MI group motivation scores 3.10 and 2.54 points higher at 6 weeks and 3 months, respectively. A quasi-experimental study by Fu and colleagues further demonstrated that MI delivered through a combination of 1 face-to-face and 3 telephone sessions significantly reduced depression scores and improved sleep quality in patients with early post-stroke depression, with effects persisting at 3 months. The combination of in-person and telephone delivery in this study represents a practical hybrid model that addresses the scheduling and accessibility challenges inherent in inpatient settings, while maintaining the therapeutic continuity necessary for sustained intervention effects. In outpatient settings, the greater continuity and flexibility of the clinician-patient relationship create opportunities for more sustained and iterative application of MI and behavioral strategies. The Department of Veterans Affairs Clinical Practice Guideline recommends clinician-guided computer and internet-based cognitive behavioral therapy as an adjunct or first-line treatment for mild to moderate major depressive disorder based on patient preference, a recommendation that's particularly feasible in outpatient rehabilitation, where patients have access to technology and the time between sessions to engage with digital therapeutic content. The VA Guideline for Stroke Rehabilitation further supports group-based CBT in the outpatient setting, with evidence demonstrating large and statistically significant improvements in general depression symptoms immediately after the intervention, and these benefits were sustained at the 3-month follow-up assessment, with a moderate treatment effect that remained clinically meaningful. In home care rehabilitation, the challenge of addressing depression and anxiety is compounded by the isolation, limited social support, and reduced access to mental health services that many homebound patients experience. The Depression Care Path Cluster Randomized Trial demonstrated that training all home health nurses to manage depression, including MI-consistent communication within routine visits, led to clinically significant reductions in depression severity among older adults with comorbid medical illness, without requiring specialized psychiatric clinicians or extra home visits. Although this study focused on nurses, the Depression Care Path model illustrates a broader principle applicable to all rehabilitation disciplines. Mental health management can be effectively integrated into existing clinical workflows by any trained rehabilitation professional. This is particularly noteworthy because it demonstrates that effective depression management can be integrated into existing home care workflows without additional staffing or resources, a critical consideration for home health agencies operating under significant financial and workforce constraints. A practice improvement initiative by Borson and colleagues further demonstrated that home-based delivery of evidence-based psychotherapy significantly improved depression, anxiety, quality of life, self-rated disability, and patient activation, with clinical efficacy equivalent across demographic groups and therapy models. Despite these promising findings, personalized care planning and shared decision-making were practiced in fewer than half of collaborative care programs for depression and anxiety, representing a significant missed opportunity to implement person-centered mental health practices in the settings where they're most needed. The implementation of population and setting-specific adaptations requires attention to the unique barriers and facilitators present in each context. In adolescent settings, barriers specific to developmental stage include resistance to adult authority and difficulty engaging caregivers, while facilitators include the use of developmentally appropriate MI processes, engaging, focusing, evoking, and planning, and alliance-building behaviors tailored to youth. In geriatric settings, cognitive and sensory impairments require simplified language, slower pacing, and the use of assistive devices, while trust-based alliance formation and consistent clinician assignment serve as key facilitators. The population and setting-specific evidence reviewed in this module reinforces the principle that rehabilitation professionals must tailor their implementation strategies to the developmental, cognitive, environmental, and relational characteristics of each clinical context rather than applying a uniform implementation approach. Module 6 examines outcome measurement and clinical documentation. The integration of mental health strategies into rehabilitation practice requires a structured approach to outcome measurement that enables clinicians to identify patients with significant depressive or anxiety symptoms, monitor symptom trajectories over the course of treatment, and evaluate the effectiveness of interventions. This module examines the validated instruments available for assessing depression and anxiety across the age spectrum, the measurement thresholds and change indices that define clinically meaningful improvement, and the principles and practical considerations governing the integration of these measures into electronic health record workflows and measurement-based care models. For adolescent populations, the International Consortium for Health Outcomes Measurement, or ICOM, recommends several standardized instruments as the foundation for systematic outcome assessment. The Revised Children's Anxiety and Depression Scale, or RCADS, the Mood and Feelings Questionnaire, or MFQ, the Short Mood and Feelings Questionnaire, or SMFQ, and the Patient Health Questionnaire Adolescent, or PHQA, are endorsed as standard outcome measures for anxiety and depression in youth. The SMFQ is a 13-item self-report tool with a validated cutoff of 12 or higher on a range of 0 to 26 for clinically significant depressive symptoms, demonstrating strong reliability and consistency across repeated administrations. The RCADS 25 provides dual assessment of both anxiety and depression with youth and parent report versions and has been validated for measurement-based care in intensive outpatient child and adolescent mental health settings. The availability of parallel parent report forms is particularly valuable in rehabilitation, where collateral information from caregivers can supplement the adolescent's self-report, especially when cognitive impairments, fatigue, or emotional distress may compromise the accuracy of self-assessment. Additional instruments with strong psychometric support include the Overall Anxiety Severity and Impairment Scale Adolescent, or OASIS-A, and the Overall Depression Severity and Impairment Scale Adolescent, or ODSIS-A, which offer brief unidimensional measures with optimal cutoff scores of 7 or higher for the OASIS-A and 5 or higher for the ODSIS-A, both demonstrating excellent reliability in psychometric testing and established measurement consistency across gender. The Pediatric Quality of Life Inventory, or PEDSQL, and the Columbia Suicide Severity Rating Scale, or CSSRS, are additionally supported for broader quality of life and suicidality assessment in intensive outpatient and rehabilitation contexts. For adult and geriatric patients, the Patient Health Questionnaire 9, or PHQ-9, and the Generalized Anxiety Disorder 7, or JD-7, are the most widely recommended instruments, endorsed by the American Psychiatric Association, the Department of Veterans Affairs, and ICOM. Both instruments are free, validated across diverse populations and languages, and sensitive to change over time, making them suitable for biweekly or more frequent administration in rehabilitation settings. The PHQ-9 assesses the 9 symptom criteria for major depressive disorder as defined by the Diagnostic and Statistical Manual and yields both a categorical diagnosis and a continuous severity score, while the GAD-7 assesses the core symptoms of generalized anxiety disorder with comparable brevity and psychometric rigor. The widespread endorsement of these instruments by major guideline organizations reflects not only their psychometric properties, but also their practical advantages. Both can be completed in under 5 minutes, require no specialized training to administer, and are available at no cost. That eliminates the licensing and procurement barriers that impede adoption of proprietary instruments in resource-constrained rehabilitation settings. The composite PHQ-ADS, which combines the PHQ-9 and GAD-7 into a single scale, and the ultra-brief PHQ-4 have demonstrated validity and responsiveness in populations with comorbid medical and psychiatric conditions, including chronic musculoskeletal pain undergoing rehabilitation. These composite instruments offer practical advantages in rehabilitation settings where administration time is limited, as they provide a full assessment of both depressive and anxiety symptoms in a single brief administration. For geriatric patients specifically, the Geriatric Depression Scale 15, or GDS-15, is validated and recommended, with demonstrated predictive validity for functional outcomes in inpatient rehabilitation. The GDS-15's simple yes or no response format makes it particularly accessible for older adults with limited literacy, cognitive impairment, or unfamiliarity with Likert scale or graded rating scale response formats. The Patient-Reported Outcomes Measurement Information System, or PROMIS, and related systems including the NeuroQOL, TBI-QOL, and SCI-QOL provide strong interpretability metrics and enhanced sensitivity to change, particularly when using computer adaptive testing formats that minimize floor and ceiling effects. The Neuropsychology Org Measures of Anxiety and Depression, or NOMAD, scale is a brief screening tool specifically designed for rehabilitation populations, with strong overall screening accuracy that correctly distinguishes the large majority of true cases from non-cases, and strong agreement with established mood measures as demonstrated through convergent validity testing. This offers a rehabilitation-specific alternative when more general instruments may not adequately capture the psychological experience of patients recovering from injury or illness. The clinical usefulness of outcome measurement depends not only on selecting appropriate instruments, but also on applying empirically derived thresholds that define clinically significant symptom levels and clinically meaningful change. For the PHQ-9, scores range from 0 to 27, with a caseness threshold of 10 or higher indicating clinically significant depression. Reliable improvement is defined as a pre-post decrease of 6 or more points, and reliable recovery requires both scoring below threshold and achieving reliable improvement. For the GAD-7, scores range from 0 to 21, with reliable improvement defined as a decrease of 4 or more points. The caseness threshold used in the National Psychological Treatment Program, from which these reliable change indices are derived, is 8 or higher. Clinicians should note that the original validation established a standard diagnostic threshold of 10 or higher, and thresholds may vary across guidelines and clinical settings. A reliable change index is a statistical threshold that determines whether a change in score exceeds what could be expected from measurement error alone, thereby confirming that observed improvement reflects genuine clinical change. These reliable change indices are essential for distinguishing genuine clinical improvement from the measurement error inherent in all self-report instruments, and their application ensures that treatment decisions are based on meaningful changes in patient status, rather than random fluctuation in scores. A recent retrospective cohort study in a national psychological treatment program further validated these thresholds across both young adult and working-age adult populations, confirming that the PHQ-9 and GAD-7 indices are applicable across the age range of adult rehabilitation patients. Without reliable change indices, clinicians risk either overinterpreting small score fluctuations as evidence of clinical change or underappreciating genuine improvements that fall below arbitrary thresholds. Both errors compromise the quality of clinical decision-making. The distinction between reliable improvement and reliable recovery deserves particular emphasis in rehabilitation contexts. A patient who achieves a 6-point decrease on the PHQ-9 demonstrates reliable improvement regardless of where the final score falls, but reliable recovery additionally requires that the final score fall below the caseness threshold of 10, indicating that the patient has moved from clinically significant depression into the subclinical range. This distinction is clinically important because a patient whose PHQ-9 score decreases from 24 to 16 has achieved reliable improvement and is clearly benefiting from treatment, yet remains in the clinically significant range and requires continued monitoring and intervention. Rehabilitation teams that track both metrics, improvement and recovery, can make more nuanced and clinically appropriate treatment decisions than those relying solely on a single threshold. The frequency of outcome measure administration is an important consideration for rehabilitation teams implementing measurement-based care. Both the PHQ-9 and GAD-7 are designed for repeated administration at intervals as frequent as every 2 weeks, enabling clinicians to track symptom trajectories in near real time and adjust treatment plans in response to observed changes. In rehabilitation settings where patients are seen multiple times per week, biweekly administration strikes a balance between clinical sensitivity and respondent burden, providing sufficient data to identify clinically meaningful trends without overwhelming patients with repetitive assessments. For the RCADS-25 in adolescent populations, administration at intake and at regular intervals throughout the course of treatment enables clinicians to monitor both anxiety and depression trajectories simultaneously, with the dual-domain structure of the instrument reducing the need for separate anxiety and depression assessments. The systematic integration of validated outcome measures into electronic health record workflows is essential for transforming mental health screening from an episodic clinician-dependent activity into a routine institutional practice that's embedded in the standard of care. The American Psychiatric Association recommends embedding validated outcome measures directly into EHR workflows, enabling automated administration, scoring, and integration of results into the patient record for real-time review of trajectories, generation of clinical alerts, and aggregation of data for quality reporting. In a single-site development and usability study, digitization of self-report assessments through REDCap, Research Electronic Data Capture, a secure web-based data collection tool integrated with EHRs, produced substantial improvements in physician adoption of integrated care pathways and patient enrollment, with significant time savings and improved data quality. These improvements in adoption and enrollment suggest that a primary barrier to measurement-based care implementation isn't clinician resistance to the concept, but rather the logistical and administrative burden of paper-based or non-integrated measurement processes. The Joint Commission, effective January 2018 and remaining in effect as of 2026, requires all accredited behavioral healthcare organizations to use standardized tools for outcome measurement, with feedback used to inform care goals, monitor progress, and guide treatment decisions. While this mandate applies directly to behavioral healthcare organizations, it establishes a standard of practice that's increasingly relevant for rehabilitation settings where patients with significant psychiatric comorbidities receive care. The regulatory trajectory established by the Joint Commission's standard signals a broader shift in healthcare accreditation toward the expectation that outcome measurement will be embedded in all clinical settings where mental health conditions are assessed and treated, not only in facilities designated as behavioral health organizations. Accreditation requirements, scope of practice regulations, and mandated screening protocols may vary by state, facility type, and professional licensure. Rehabilitation professionals should consult their state licensing boards and institutional policies to confirm applicable requirements. The Department of Veterans Affairs promotes a three-component model of measurement-based care for depression: collect, using validated measures such as the PHQ-9, share, with results discussed with the patient and all relevant providers, and act, with results used to adjust care plans in response to observed trajectories. This Collect Share Act framework provides a straightforward operational model for rehabilitation teams seeking to integrate mental health outcome measurement into their existing clinical workflows without requiring fundamental reorganization of care delivery processes. The share component of this model is particularly noteworthy because it requires that measurement results be communicated not only within the clinical team, but also to the patient. This transforms outcome measurement from a clinical surveillance tool into a collaborative, patient-centered process that supports the therapeutic alliance and shared decision-making principles discussed in Modules 2 and 3. When patients are shown their own symptom trajectories over time, they can see objective evidence of their progress, which reinforces engagement and self-efficacy. Or they can see evidence of stagnation or worsening, which creates a natural opening for collaborative discussion about treatment modifications. Despite the strong evidence base supporting measurement-based care, implementation in clinical practice remains limited. Fewer than 20% of behavioral health practitioners routinely employ measurement-based care, and even fewer adhere to empirically informed schedules of administration. Key barriers include clinician skepticism about the added value of standardized measurement over clinical judgment, time and administrative burden, concerns about punitive use of measurement-based care data for performance evaluation, and lack of EHR integration. Clinician skepticism, while understandable given the already substantial documentation demands in rehabilitation, isn't supported by the evidence. Measurement-based care consistently produces better outcomes than clinical judgment alone because it provides objective, standardized data that are resistant to the cognitive biases and anchoring effects that influence even experienced clinicians' subjective assessments. Facilitators of successful implementation include the use of freely available measures such as the PHQ-9 and GAD-7, targeted clinician training that emphasizes the clinical value rather than the administrative burden of outcome measurement, identification of clinic champions who model and advocate for measurement-based practices, and technology-enhanced measurement-based care using mobile applications and digital platforms that increase patient willingness and ease of use. Technology-enhanced approaches are particularly promising because they shift the administrative burden of data collection, scoring, and tracking from clinicians to automated systems, allowing clinicians to focus their limited time on interpreting results and making clinical decisions rather than on the mechanical processes of measurement administration. For rehabilitation populations with cognitive impairments, such as stroke and neurorehabilitation patients, patient-reported outcome measure design should optimize cognitive accessibility through simplified content, clear visual layout, and supported administration procedures that include verbal guidance and environmental modifications to reduce cognitive demand. Collaborative care models that systematically integrate patient and family engagement with measurement-based care have demonstrated superior outcomes compared to standard approaches. The resource group method, evaluated by Tiarden and colleagues in a randomized clinical trial of 142 patients with severe mental illness, involves patients directing quarterly meetings of their informal and formal support networks to discuss recovery goals and develop joint plans, producing improved empowerment, quality of life, and functioning. While developed outside the rehabilitation context, the resource group model's emphasis on patient-directed, goal-oriented collaboration with both professional and informal supporters offers a template for rehabilitation teams seeking to integrate measurement-based mental health care within a broader framework of patient and family-centered practice. The evidence reviewed in this module establishes that validated outcome measures for depression and anxiety are available, psychometrically sound, and practically feasible for implementation across the full range of rehabilitation populations and settings. The challenge facing rehabilitation professionals isn't a deficit of appropriate tools, but rather the need for systematic integration of those tools into routine clinical workflows, supported by institutional commitment to training, technology infrastructure, and a culture of measurement-based practice that values objective data as a complement to clinical expertise. Module 7 addresses interdisciplinary communication, discharge planning, and continuity of care. The mental health strategies examined throughout this course, motivational interviewing, therapeutic alliance building, behavioral activation, population-specific adaptations, and measurement-based care, achieve their full clinical potential only when embedded within a structured, interdisciplinary framework that supports coordinated assessment, intervention, and continuity across the rehabilitation episode and beyond. This module addresses the organizational and communicative infrastructure required to sustain effective mental health care in rehabilitation. The key components of effective interdisciplinary communication and discharge planning for mental health continuity include structured interdisciplinary team meetings with clearly defined roles and shared documentation, patient and family engagement in care planning, including psychoeducation and caregiver involvement, pre-discharge scheduling of outpatient mental health appointments, transitional care models with bridging interventions combining case management and psychoeducation, and digital health tools including telehealth, mobile health applications, and remote monitoring platforms that extend intervention beyond the rehabilitation episode. Each of these components is examined in the sections that follow. Regular, structured interdisciplinary team meetings are foundational to effective rehabilitation care, providing a forum for collaborative goal setting, care plan development, and real-time problem-solving that integrates the perspectives and expertise of all team members. Rehabilitation psychologists are often positioned to lead these meetings, drawing on expertise in team dynamics, psychological safety, a team climate in which members feel safe to speak up without fear of judgment, and conflict resolution to create an environment in which all disciplines can contribute meaningfully to the care planning process. The effectiveness of these meetings depends on clear delineation of roles and responsibilities among team members, following a staged approach that begins with identification of shared purpose, proceeds through role definition and task assignment, and culminates in integration of individual contributions into a cohesive, patient-centered workflow. Contemporary research confirms that these staged processes remain operationally relevant, while emphasizing that interprofessional communication in rehabilitation is dynamic and distributed, involving both formal structured interactions and informal exchanges that shape real-time clinical decision-making. This staged model ensures that mental health considerations aren't siloed within the purview of a single discipline, but rather distributed across the full team, with each member understanding their role in identifying, monitoring, and addressing the psychological barriers to functional recovery, discussed in preceding modules. The communication modalities through which interdisciplinary teams exchange clinical information significantly influence the quality and efficiency of mental health care in rehabilitation. A scoping review of interprofessional communication in rehabilitation found that informal communication, hallway consultations, brief exchanges during patient care, and ad hoc discussions is where critical information is often exchanged. But it can be time-consuming and prone to error if not well managed within a structured communication framework. Interview studies confirm that interprofessional communication contributes significantly to the workload of healthcare professionals, and teams should allocate resources accordingly. Streamlining communication through standardized handoff tools, shared progress notes, and real-time messaging platforms reduces the cognitive and temporal burden of information exchange. Shared documentation within the electronic health record allows for transparent communication and continuity across providers and should include mental health screening results, behavioral health interventions, and follow-up plans accessible to all relevant team members. The integration of mental health metrics into shared EHR documentation, as discussed in Module 6, transforms outcome measurement data from a tool used by individual clinicians into a shared resource that informs the entire team's understanding of the patient's psychological status and treatment trajectory. Patient and family engagement is a central tenet of effective interdisciplinary communication and has been demonstrated to directly influence the continuity and quality of mental health care across care transitions. Family involvement in psychiatric hospitalizations is significantly associated with thorough discharge planning and prompt entry into outpatient care. Inpatient staff contact with family members was associated with patients attending an outpatient appointment by 7 days, with nearly threefold higher odds of follow-up attendance, a statistically significant finding that is unlikely to be due to chance, and by 30 days, with approximately threefold higher odds that are similarly robust and statistically significant after discharge. The magnitude of these findings, indicating nearly a threefold increase in the likelihood of timely outpatient follow-up when families are engaged during inpatient care, shows the critical role of family involvement in ensuring that mental health gains achieved during rehabilitation are sustained through successful transitions to outpatient services. The Department of Veterans Affairs emphasizes that family services, including psychoeducation, communication skills training, and problem-solving interventions, lead to improved treatment adherence, fewer psychiatric symptoms and relapses, and enhanced family functioning. These findings extend the family engagement imperative beyond discharge planning to encompass the ongoing active involvement of family members as partners in the patient's mental health care throughout the rehabilitation episode and into the community. When families understand the nature of the patient's depression or anxiety, the strategies being employed to address it, and their own role in supporting the patient's recovery, they become extensions of the treatment team whose influence persists long after formal rehabilitation services have concluded. Workforce capacity building through cross-training and joint professional development enhances mutual understanding between rehabilitation and behavioral health providers, particularly in settings where access to behavioral health specialists is limited. Organizational partnerships and well-coordinated referral procedures with external behavioral health providers are essential to avoid fragmented care pathways that leave patients without adequate mental health support during and after rehabilitation. The integration of mental health expertise into rehabilitation teams, whether through embedded behavioral health providers, cross-trained rehabilitation clinicians, or formal referral networks, ensures that the strategies discussed throughout this course can be implemented consistently, regardless of the specific resources available at any given rehabilitation facility. Sociocultural, socioeconomic, and health literacy factors significantly impact the effectiveness of mental health outcome tracking and continuity of care, and rehabilitation professionals must attend to these determinants to ensure equitable implementation of the strategies discussed in this course. The American Psychological Association Guidelines for Practice with People Experiencing Low Income and Economic Marginalization emphasize that low income and economic marginalization status contributes to health disparities through greater stress, unhealthy environments, poorer health behaviors, and reduced access to quality health care. A Dutch nationwide cohort study found that individuals with higher education and income experienced greater improvement after mental health treatment, while those with lower socioeconomic status had less favorable outcomes. This suggests that the benefits of mental health intervention are unequally distributed across the socioeconomic spectrum. Health literacy mediates the relationship between socioeconomic status and health status, quality of life, and health behaviors, with low educational attainment being the most important determinant of health literacy. Rehabilitation professionals must consider clients' health literacy to optimize practice, as it impacts capacities, functioning, participation, empowerment, and access to services, all of which are directly relevant to the measurement-based care and behavioral strategies discussed in preceding modules. These considerations are particularly important when implementing standardized outcome measures, as patients with limited health literacy may require modified administration procedures, simplified instructions, or supported completion to ensure that their responses accurately reflect their psychological status. The transition from rehabilitation to community-based care represents a critical vulnerability in the continuity of mental health services, and structured discharge planning is essential to prevent the disruption of treatment gains achieved during the rehabilitation episode. Scheduling outpatient mental health appointments prior to discharge is a high-impact, low-resource intervention. Patients with scheduled appointments were significantly more likely to attend follow-up within 7 days, with a statistically significant 69% increase in the likelihood of attending follow-up, a finding that is robust and reliable, and within 30 days, with a similarly strong and statistically significant 65% increase in follow-up attendance. For adolescents, timely outpatient follow-up within 7 days of discharge is associated with a significantly lower risk of suicide in the 6 months following discharge, yet nearly half of youths fail to receive care meeting this standard. The American Academy of Pediatrics recommends thorough psychosocial assessment for hospitalized adolescents, with social workers for initial assessment, mental health liaison services, and follow-up appointments made before discharge to limit barriers attributable to insurance, transportation, and provider accessibility. The American Academy of Child and Adolescent Psychiatry emphasizes assertive discharge planning, patient and family psychoeducation, and proactive linkage to care, especially for those without prior outpatient engagement. Together, these guidelines establish pre-discharge scheduling as a minimum standard of care that rehabilitation teams can implement with minimal resource investment and substantial clinical impact. Transitional care models with bridging interventions, combining case management, psychoeducation, and home-based support show positive improvements in quality of life, shared decision-making, and connections to primary and specialty care, though their impact on readmission rates isn't definitive, showing a trend toward roughly 24% lower readmission rates that did not reach statistical significance. A meta-analysis of 12 randomized controlled trials with 3,663 participants found only a modest and statistically non-significant reduction in psychiatric readmissions from post-hospitalization interventions overall, suggesting that a one-size-fits-all approach is unlikely to be optimal, and that targeted, patient-specific approaches are needed. The ENRICH trial, a large randomized controlled trial of peer support for discharge from inpatient mental health care involving 590 participants, found no statistically significant difference in 12-month readmission rates between the peer support group and the control group, though qualitative data suggest benefits in recovery, social wellness, and community connection. These findings indicate that the value of transitional care interventions may lie less in reducing readmission rates and more in improving the quality, connectedness, and patient-centeredness of the transition experience, outcomes that are central to the integrated, patient-centered approach to mental health care advocated throughout this course. Psychoeducation, especially in group and family formats, has the strongest evidence for reducing relapse and hospitalization among transitional care strategies, with more than 30 randomized controlled trials demonstrating reduced non-adherence, fewer relapses, and lower hospitalization rates. Brief psychoeducation consisting of 10 or fewer sessions reduces relapse rates by approximately 30% in the medium term, a statistically significant and clinically meaningful reduction, and promotes medication compliance in the short term with approximately 37% lower rates of non-adherence, another statistically significant finding. For geriatric patients, detailed discharge planning involving advanced practice nurse assessment of physical, functional, cognitive, and emotional health, individualized care plans, caregiver education, and coordination of home services has been validated in a randomized clinical trial. System-level policies can further enhance transition efficiency, A seamless care transition policy implemented in Edmonton, Alberta, reduced wait times for initial mental health therapist assessments from a median of 12 days to 6 days, and for psychiatric assessments from 14 days to 7 days, with a slight decline in readmission rates. Digital health tools offer expanding opportunities to maintain continuity of mental health care across transitions from rehabilitation to community settings. Mobile apps and remote monitoring platforms enable frequent, real-time assessment of symptoms, with evidence indicating that a growing majority of individuals with serious mental illness now own smartphones. Recent studies report ownership rates of 60 to 77%, though a digital divide persists for older adults, those with psychotic disorders, and individuals with lower socioeconomic status. Telehealth promotes collaborative care and improves outcomes in depression, PTSD, and ADHD, particularly in pediatric populations where geographic barriers and limited specialist availability may otherwise prevent access to evidence-based mental health services. In geriatric rehabilitation, mobile health interventions have shown positive effects on health status, though standardized measurement and integration into daily practice remain limited. The American Association for Geriatric Psychiatry highlights the need for inclusive design and tailored interventions to address social determinants such as isolation and loneliness in older adults. Across all age groups, engagement with digital mental health tools is maximized when they're embedded within a broader ecosystem of care, supported by human facilitation such as digital navigators who assist patients in accessing and using technology, and integrated into clinical workflows rather than offered as standalone interventions. The evidence reviewed in this module shows that effective mental health care in rehabilitation extends far beyond the individual clinician-patient encounter. It requires organizational infrastructure, structured team meetings, shared documentation, family engagement, pre-discharge scheduling, transitional care models, and digital continuity tools that supports the consistent, coordinated, and equitable delivery of the evidence-based strategies examined throughout this course. Rehabilitation professionals should consider how the MI, alliance building, and behavioral strategies discussed in preceding modules can be extended through digital platforms. For example, using telehealth sessions to deliver brief MI interventions, incorporating mobile-based symptom monitoring into the Collect, Share, Act framework of measurement-based care described in Module 6, and employing digital communication tools to maintain the therapeutic alliance across care transitions. The organizational infrastructure discussed in this module, structured team meetings, shared EHR documentation, family engagement, and pre-discharge scheduling, provides the foundation upon which these digital tools can be effectively integrated to support mental health continuity beyond the rehabilitation episode. Module 8 presents 4 clinical case studies that integrate the evidence-based strategies and principles examined across modules 1 through 7. Each case presents a rehabilitation patient with comorbid depression or anxiety and illustrates the application of motivational interviewing, therapeutic alliance building, behavioral strategies, population and setting-specific adaptations, outcome measurement, interdisciplinary communication, and discharge planning within a realistic clinical scenario. These cases are designed to reinforce the practical application of course concepts across diverse patient populations, care settings, and clinical challenges. Case Study 1 presents a geriatric patient in inpatient rehabilitation following hip fracture with comorbid depression. Mrs. Chen is a 78-year-old woman admitted to inpatient rehabilitation following surgical repair of a left hip fracture sustained in a fall at home. Her medical history includes hypertension and osteoarthritis. During the initial nursing assessment, she presents with flat affect, diminished appetite, and statements of hopelessness about her ability to return home. The rehabilitation team notes that she's reluctant to participate in transfers and ambulation training, citing fatigue and pain despite adequate analgesic management. Her geriatric depression scale 15 score is 9 and her PHQ-9 score is 14, both indicating clinically significant depressive symptoms. Research has demonstrated that in geriatric inpatient rehabilitation, depression assessed by the GDS-15 independently predicts lower functional independence measure scores at discharge, and this association is statistically significant, almost certainly not due to chance, after controlling for baseline disability, pain, cognition, and educational level. The prevalence of depressive symptoms in older rehabilitation inpatients is approximately 31 to 32%, regardless of the primary diagnosis, establishing that Mrs. Chen's presentation is common rather than exceptional. The clinician initiates motivational interviewing using OARS techniques, employing open-ended questions to explore Mrs. Chen's values and priorities regarding recovery, and affirmations to reinforce her efforts and strengths. These approaches are particularly important for individuals experiencing the low motivation characteristic of depression. Given her age, the clinician adapts MI delivery by using simplified language, slower pacing, and repeated key instructions, consistent with evidence that cognitive and sensory impairments require these modifications in geriatric populations. The team implements behavioral activation, recommended by the Department of Veterans Affairs as a first-line psychotherapy, emphasizing structured activity scheduling, mood tracking, and functional analysis of barriers. Both BA and CBT have demonstrated large and clinically meaningful reductions in depressive symptoms in inpatient psychosomatic rehabilitation, as measured by the Beck Depression Inventory 2, with no significant difference between the two approaches. BA is selected for Mrs. Chen because it requires fewer cognitive resources than traditional CBT. The rehabilitation team builds the therapeutic alliance through demonstrated clinical competence and consistent expressions of respect, aligning with qualitative research demonstrating that trust in the therapist's abilities and feelings of mutuality are central to motivation in geriatric hip fracture rehabilitation. A cluster randomized clinical trial found that MI improved therapeutic adherence in patients over 65 with chronic diseases, demonstrating nearly threefold higher odds of treatment adherence compared to advice-based approaches. Mrs. Chen's PHQ-9 and GDS-15 are administered biweekly, consistent with recommendations from the American Psychiatric Association, the Department of Veterans Affairs, and ICOM. By the third week, her PHQ-9 has decreased from 14 to 8, exceeding the reliable improvement threshold of a 6-point decrease and achieving reliable recovery by falling below the caseness threshold of 10. She's discharged home with a pre-scheduled outpatient mental health appointment, a structured activity plan, and family psychoeducation to maintain treatment gains. Case Study 2 presents an adolescent in outpatient rehabilitation with anxiety-driven avoidance. Marcus is a 16-year-old male referred to outpatient physical therapy following ACL reconstruction. He presents with marked anxiety about re-injury, avoidance of weight-bearing exercises, and declining attendance at therapy sessions. His parents report that he has withdrawn from peers and stopped participating in activities he previously enjoyed. His ARCADS 25 score indicates elevated anxiety, and his ODSIS-A score of 7 meets the clinical cutoff of 5 or higher. The treatment team recognizes that adolescent-specific adaptations are essential. The National Institute on Alcohol Abuse and Alcoholism highlights that MI is particularly well-suited for adolescents because it avoids confrontation, respects individuality, and supports autonomy. The clinician applies MI's 4 processes: engaging, focusing, evoking, and planning, as recommended by the American Academy of Pediatrics for tailoring interventions to the adolescent stage of change. Given evidence that MI, as a pre-treatment intervention, significantly increases treatment attendance and readiness in adolescents with anxiety and mood disorders compared to active control, the clinician dedicates the first 2 sessions to engagement and motivational exploration before introducing progressive rehabilitation exercises. Alliance building with Marcus requires specific clinician behaviors identified in the literature, including collaboration, finding common ground, exploring subjective experiences, and providing praise with a statistically significant positive effect of these behaviors on therapeutic outcomes. The clinician is particularly attentive to avoiding alliance-reducing behaviors, such as being overly directive or dismissive, whose damaging impact on the therapeutic relationship substantially exceeds the beneficial effect of positive alliance-building behaviors. The alliance mediates outcomes through enhanced emotion regulation. Research in internet-based treatments for adolescent depression demonstrates that alliance ratings predict improvements in emotion regulation, which in turn predicts symptom reductions. The team monitors Marcus's progress using the ARCADS 25, which provides dual assessment of anxiety and depression with validated youth and parent report versions. His parents are actively engaged in treatment planning, consistent with evidence that family involvement substantially increases the likelihood of timely outpatient follow-up. As Marcus approaches discharge, the team schedules outpatient mental health follow-up within 7 days, reflecting evidence that timely follow-up is associated with a significantly lower risk of suicide in the 6 months after discharge. Over 8 weeks, Marcus demonstrates progressive engagement in rehabilitation tasks, normalization of anxiety scores, and return to age-appropriate physical activities. Case Study 3 presents an adult stroke survivor in home care with post-stroke depression. Mr. Williams is a 58-year-old man receiving home-based rehabilitation services following a left middle cerebral artery stroke. He presents with right hemiparesis, fatigue, and symptoms consistent with post-stroke depression, including persistent sadness, reduced motivation for therapy, and sleep disturbance. His PHQ-9 score is 18, indicating moderately severe depression. The American Heart Association and American Stroke Association guidelines state that post-stroke depression exerts negative effects on functional recovery, and that pharmacological treatment can counterbalance this effect with remission of depression associated with greater recovery in activities of daily living. In young and middle-aged first-onset stroke patients, structured multidisciplinary rehabilitation produces substantial reductions in depressive and anxiety symptoms. The home health team integrates MI into routine visits using the depression care path model, which demonstrated that training all home health nurses to manage depression, including MI-consistent communication, within routine visits, led to clinically significant reductions in depression severity among older adults with comorbid medical illness, without requiring specialized psychiatric clinicians or extra home visits. A quasi-experimental study in early post-stroke depression found that MI delivered through 1 face-to-face and 3 telephone sessions significantly reduced depression scores and improved sleep quality, with effects persisting at 3 months. The clinician uses MI-based goal-setting sessions, with evidence demonstrating 86% uptake and 69% of patient-centered goals achieved at discharge using this approach. Physical activity integration is central to Mr. Williams's care plan, given meta-analytic evidence of moderate to large treatment benefits for exercise in improving depressive symptoms. The team follows practical recommendations for open, explorative goals, mental contrasting with implementation intentions, supervised sessions, and focusing on one behavioral change at a time. The interdisciplinary team maintains coordination through shared EHR documentation that includes mental health screening results, behavioral health interventions, and follow-up plans, with regular structured team meetings providing a forum for collaborative goal setting and problem solving. As discharge from home health services approaches, the team schedules outpatient mental health follow-up, consistent with evidence that pre-discharge scheduling significantly increases follow-up attendance, showing a statistically significant 69% increase in the likelihood of attending the 7-day follow-up appointment. Transitional care with bridging interventions supports quality of life and connections to community care. The team introduces a mobile health application for remote symptom monitoring, reflecting evidence that digital tools enhance continuity when embedded within a broader care ecosystem and supported by human facilitation. After 12 weeks of home-based rehabilitation, Mr. Williams's PHQ-9 has decreased from 18 to 9, achieving both reliable improvement and reliable recovery, and he transitions successfully to outpatient follow-up with sustained functional gains. Case Study 4 presents an adult cardiac rehabilitation patient with comorbid anxiety and amotivation. Ms. Torres is a 52-year-old woman enrolled in outpatient cardiac rehabilitation following myocardial infarction. She presents with persistent anxiety about cardiac events during exercise, a motivation to attend sessions, and low confidence in her capacity for physical recovery. Her PHQ-9 score is 12 and her GAD-7 score is 13, both exceeding clinical thresholds. In psychocardiological rehabilitation, higher baseline depressive symptoms significantly increase the odds of limited workability, with roughly 78% higher odds of limited work capacity, a finding that is statistically significant and highly unlikely to be due to chance, while reductions in anxiety symptoms are associated with improved workability and quality of life. The cardiac rehabilitation team implements intermittent MI delivery throughout the course of therapy rather than as a single pre-treatment intervention, consistent with evidence that integrating MI across CBT sessions significantly outperforms CBT with psychoeducation alone, demonstrating a medium-sized and clinically meaningful treatment benefit. The team focuses on eliciting change talk, patient statements indicating desire, ability, reason, or need for change, a core MI skill demonstrated to mediate treatment outcomes. Brief action planning is introduced as an adjunct, using collaborative, SMART goals, confidence scaling, and problem solving to reduce barriers and strengthen the alliance. When Ms. Torres rates her confidence in completing a planned walking program at 5 out of 10, the clinician collaboratively problem solves specific barriers, which include fear of exertion and scheduling conflicts with work obligations. Physical activity integration follows evidence-based practical strategies, including open, explorative goals, mental contrasting with implementation intentions, and supervised sessions focusing on one behavior at a time for highly motivated patients. The team monitors symptoms biweekly using the PHQ-9 and GAD-7 within a measurement-based care framework consistent with the Department of Veterans Affairs Collect Share Act model. Validated measures are collected, results are shared with the patient and all relevant providers, and findings are used to adjust care plans. The interdisciplinary team coordinates through regular structured meetings, with the cardiac rehabilitation program maintaining organizational partnerships and well-coordinated referral procedures with external behavioral health providers to ensure integrated care. Over 12 weeks, Ms. Torres's GAD-7 decreases from 13 to 6, achieving reliable improvement of 4 or more points and falling below the caseness threshold of 8, indicating reliable recovery. Her PHQ-9 decreases from 12 to 7, also achieving reliable recovery. She demonstrates progressive increases in exercise tolerance, reports improved confidence in her physical capacity, and successfully returns to part-time employment. Her case illustrates the synergistic effects of motivational interviewing, behavioral strategies, measurement-based care, and interdisciplinary coordination in addressing comorbid anxiety and Amotivation in cardiac rehabilitation. Thank you for completing this course. We will now review the exam questions to solidify your understanding. Question 1. In geriatric inpatient rehabilitation, which of the following best describes the relationship between depression and functional outcomes at discharge? The correct answer is C. Depression at admission predicts significantly lower functional independence measure scores at discharge, after accounting for baseline disability, pain, cognition, and education level. Rationale. Research demonstrates that in geriatric inpatient rehabilitation, depression assessed by the Geriatric Depression Scale 15 is an independent predictor of lower functional independence measure scores at discharge, with a standardized beta of negative 0.151 after controlling for baseline disability, pain, cognition, and educational level. This finding establishes that mood disturbance can undermine the rehabilitation process, even when physical and cognitive factors are adequately addressed. Question 2. According to the evidence presented in the course, how does depression function in the context of rehabilitation outcomes? The correct answer is A. As an independent predictor of poorer functional recovery across diverse populations. Rationale. The evidence consistently demonstrates that depression functions as an independent predictor of poorer functional recovery across diverse rehabilitation populations, settings, and outcome measures. High baseline depressive symptoms predict substantially lower odds of functional recovery after stroke, heart attack, or hip fracture, confirming that depression operates as a transdiagnostic risk factor rather than a secondary correlate or disease-specific phenomenon. Question 3. The AWRS acronym used in motivational interviewing represents which set of foundational techniques? The correct answer is D. Open-ended questioning, affirmations, reflective listening, and summarizing. Rationale. The foundational motivational interviewing techniques are open-ended questioning, affirmations, reflective listening, and summarizing, collectively known by the acronym AWRS. These techniques remain central to the motivational interviewing approach in rehabilitation and are tailored to address the unique needs of patients with comorbid mood and anxiety disorders. Question 4. Research found that brief motivational interviewing interventions, consisting of as few as 2 sessions, totaling what duration were as effective as longer interventions for enhancing treatment attendance? The correct answer is B. 15 minutes. Rationale. Short motivational interviewing interventions, consisting of as few as 2 sessions totaling 15 minutes, were found to be as effective as longer interventions for enhancing treatment attendance. This finding suggests motivational interviewing can be feasibly integrated into the time-constrained clinical encounters characteristic of rehabilitation practice. Question 5. A physical therapist implementing evidence-based rehabilitation protocols observes that patients with similar diagnoses and comparable baseline function achieve markedly different outcomes. Considering the evidence presented on early therapeutic processes, the therapeutic alliance measured by the third or fourth session serves which clinical function? The correct answer is A. It is a strong predictor of subsequent therapeutic outcomes, representing a critical window for establishing the relational foundation of care. Rationale. The alliance, particularly as measured early in treatment by the third or fourth session, is a strong predictor of subsequent therapeutic outcomes. This supports the clinical principle that the first 3 to 4 sessions represent a critical window for establishing the relational foundation upon which effective treatment is built. Question 6. Which of the following best describes behavioral activation as used in rehabilitation settings? The correct answer is C. A structured approach that targets the cycle of withdrawal and inactivity by systematically scheduling valued activities. Rationale. Behavioral activation is a structured therapeutic approach that targets the cycle of withdrawal and inactivity, maintaining depression by systematically scheduling valued activities. It uses 3 core components: activity scheduling, mood monitoring, and functional analysis of behavioral barriers. The Department of Veterans Affairs recommends it as a first-line psychotherapy for depression. Question 7. According to the course, the dual benefit of exercise in rehabilitation is that it simultaneously improves which 2 domains? The correct answer is D. Physical function and depressive symptoms. Rationale. The dual benefit of exercise is that it simultaneously improves physical function and reduces depressive symptoms, making physical activity integration one of the most efficient therapeutic strategies available to rehabilitation teams. This allows clinicians to advance both rehabilitative and mental health objectives within a single treatment session. Question 8. A geriatric rehabilitation team currently relies on an advice-based approach to promote treatment adherence among older patients with chronic conditions. Based on the cluster randomized clinical trial evidence presented in the course, motivational interviewing for patients over 65 years old with chronic diseases demonstrated which outcome compared to this advice-based approach? The correct answer is A. Nearly 3-fold higher odds of treatment adherence. Rationale. A cluster randomized clinical trial by Morrill and colleagues found that motivational interviewing improved therapeutic adherence in patients over 65 with chronic diseases, with the motivational interviewing group demonstrating nearly 3-fold higher odds of treatment adherence compared to an advice-based approach. This finding demonstrates that engaging older patients collaboratively is far more effective than simply telling them what to do. Question 9. On the Patient Health Questionnaire 9, what pre to post decrease in score defines reliable improvement? The correct answer is B, a decrease of 6 or more points. Rationale. For the Patient Health Questionnaire 9, reliable improvement is defined as a pre to post decrease of 6 or more points. This reliable change index distinguishes genuine clinical improvement from the measurement error inherent in all self-report instruments, ensuring treatment decisions are based on meaningful changes in patient status. Question 10. According to the evidence presented, scheduling outpatient mental health appointments prior to discharge results in which of the following? The correct answer is C. A statistically significant increase in the likelihood of attending follow-up appointments. Rationale. Scheduling outpatient mental health appointments prior to discharge demonstrated a statistically significant 69% increase in the likelihood of attending the 7-day follow-up appointment and a 65% increase at 30 days. This establishes pre-discharge scheduling as a high-impact, low-resource intervention for mental health continuity. Thank you for completing this course review. We wish you the best as you apply these evidence-based strategies in your clinical practice.